And I was just discussing that how many surgeries I would have done. Actually, I lost count. I was counting till, I was trying to be specific, 2000, 2200, 300, and the longest follow-up. And Sanjay did inform me that, my probably first lens was somewhere around 2013 or 2012. And then I tried to look up my cases where I've had complications of cataract, and they're negligible. Maybe I can count them on fingers, patients who had cataracts. So when it comes to materials, I think this is a well-tested material. It's an hydrophilic 26% water content material. I have no financial relationship or interest in anything of any of the products I'm talking about here. There is a lot of options available, at least in the Indian market. I don't know whether they are available. Available for our European friends there. We have Appasamy lens available. We have RIL. We have a biotech lens available. We have the famous ICL, and of course, my favorite, IPCL. In fact, in my practice, I have shifted nearly 99% to an IPCL. My ICLs are practically negligible now, only if the patient asks for it. And even if they ask for it, I kind of demotivate them and swing them around for an IPCL for reasons that, I still feel they are the best. So contraindications for a phakic could be general, axial myopia, corneal dystrophies. Of course, these are, some of them are relative contraindications. Anterior chamber depth less than 2.8 is a contraindication, but yes, I'm sure all of you would agree, if it's a good case workup and your angles are fine, you can get away with a lesser anterior chamber depth. I have done lenses with 2.65 also, but I would not recommend everybody to do that. Yes, I have burnt my hands in 1 or 2 cases, but then we'd already told the patient that, there would be some kind of a cataract. Lens rise is something very interesting. A lens rise more than 600 microns, a little bit cautious, shallow glaucoma, shallow angles. And I had 2 patients, which I've discussed with people at Care Group, that they were kind of decentering and vaulting again and again, in spite of best sizing. And then when I did a UBM, and I found that they had irises. So after that, I made it kind of regular for me to do a UBM before I plan a phakic lens in these patients. The powers available are huge. I've done till -36, and I've done till plus 8.5 of phakic IOL. I've done presbyopic IPCLs. I'm sure Dr. Powell has got a huge, and Dr. Bianchi have probably far more larger experience in the presbyopic category. The workup for them remains the same, with a few exceptions of their age and their defocus curve and finding that, and their height and their depth of reading. What I like best about this particular lens is an IPCL, that the sizes available are amazing. You can actually tailor make the size and planning of the lens according to your choice, and it depends on the pupil diameter, which I'll be discussing as we move along. So it's available from 11.5 to 14. I've done till 14.5. The optic diameter, I have placed IPCLs up to 8.5 millimeter optic diameter, and they work great. The beautiful point about workup of patient who's taking up for a phakic IOL with an IPCL is that you all need to put it just 0-180, because it's a smart lens and you get the job done. The biggest the reason I swing to phakic lens, especially in my toric patients, is because the accuracy. It's a beautifully accurate lens, and we've done more than 2,345 cases. This is the punchline, I guess. Refraction always done under dilatation is what I recommend, because a lot of times when you see a myopic patient, people are very well aware that in a hypermetropic patient, you need to do a cycloplegic refraction and then give a correction. But even in my myopic patients I've seen, some of them are wearing overcorrected glasses. I had a patient 4 months ago. She was wearing -6. She came to me for, IPCL, a cornea was thin. And on dilatation, I realized that she was overcorrected and she was wearing more power than required. So these are the patients who can go unmasked if you don't dilate them cycloplegic and find out the power. Another thing is, you always do a white-to-white measurement, whatever is your preferred nomogram. But in case your astigmatism is more than 2 diopters, I recommend doing a vertical white-to-white also, because that gives me a lot of a great idea about the width of the lens, especially if I'm going to use a larger optic. If I have a vertical the diameter with me, it's far more better. Now, third important thing in workup is seeing the pre-operative scotopic size. This is very important because if you have patients of high myopia with a very large pupil size, you should know the undilated scotopic pupil size. That gives you an approximate idea what is the kind of IPCL size you're looking for. Another thing you should look for is what is the maximum possible dilatation, because in case you're going in for a 14 millimeter lens and an 8 millimeter or a 7.4 millimeter optic diameter, but your pupil doesn't dilate beyond 8, you're in a fix. So for a beginner, this would be a good tip, that also check the preoperative dilatation, because some of the patients may not dilate completely. And especially if you have a larger cornea, because for a larger cornea, you'll be going in for a larger lens. And in case your pupil diameter is not large enough, it'll be very difficult for you to place the loops of the lens behind the iris. Another tip is keratoconus patients, be careful, because a lot of times in keratoconus patients, you'll have a false anterior chamber depth. You'll have a very good anterior chamber depth in the center or paracentral, but suddenly the cornea steeples down and you'll have a shallow angle and you may not have a good anterior chamber depth. So for keratoconus patients, it's very, very important to do a gonioscopy and also do an OCT to see angles 360 degrees. Posterior segment examinations are very, very important for these patients because these are high myopes and they are more prone to having retinal detachments and other retinal pathologies. You should always do that. And as I mentioned about lens rise, intraocular pressure records, gonioscopy, angle measurements, and of course the specular microscopy. What are the breaking points which can happen? Retinal screening, if you miss and the patient lands up with a problem later on, you can land up in trouble for missing it. Extremes of power, extremes of large cornea, extremes of deep cornea. Always make sure that you do meticulous calculations. Large size resting pupil, you need a larger optic. And for a beginner surgeon, if you want to go in for a larger optic size of a phakic lens, let's say 7.2 or a 7.5, be careful. Even loading this lens in the cartridge is tricky. I remember when first time I was loading a larger lens into the cartridge, it was tricky because an 8 millimeter pupil size was a large pupil size. If you want to use a miotic, always remember that a miotic for first 2-3 days will give you a shallow vault post-operatively. If you see minimal opacities behind the lens within 1 or 2-3 days, don't worry, this is not cataract. Just do an anterior segment OCT. This could be a retained viscoelastic. Watch out for intraocular pressure rise. Some patients may show intraocular pressure rise initially because of the retained viscoelastic. But in case you're getting a delayed intraocular pressure rise, maybe after 5 to 7 days, this could be a steroid responder. So watch out for steroid responders. So as I said, measuring of the pupil size, now I'll go faster, is very, very important. If you measure the pupil properly, your planning and your incidence of night glares goes down. We use dynamic pupilometry on my Cirrus machines. A lot of, and the best way to measure the pupils, the white to white in these patients is go at the mid limbus. You can use a slit lamp. A lot of people, my friends, use a vernier caliper. But for me personally, caliper is not so accurate because I've seen in a caliper in a surgeon's hand from one patient to another patient, one reading to another reading, it may vary. So I use a caliper only to confirm my findings of the machine. You can also use your standard ARK machine, which I've shown here. And we've standardized all our machines. So even in the centers where we don't have machines like Islemasters or Pentacam or Cirrus, we use our ARKs and we standardize. We get very, very decent results, and it works in all these patients. Now, if the anterior chamber depth is 2.8 or more, are you safe? Well, maybe yes or no. Even in case you have a better, larger depth, if the angles are not good, this patient is not a good candidate. If the iris configuration is very flat, not a good candidate. If there are some iris cysts in these patients, in spite of the fact that the patient's got a deep chamber, not a good case. If you have a lens rise of 800 millimeter or 850 or 700, and the angles are open, then again, you should plan for a higher vault in case, even if the anterior chamber depth is 2.8, you should plan for a vault, maybe 700, 800 plus. Normally, we plan our vaults anything between 400 and 700, but if you have a high lens rise, go in for a higher length vault. Keratoconus, as I said, we need to be very careful. Now, this is what I mean by a lens rise. In lens rise, what you do is you take an anterior segment OCT, dilate the patient, take an angle-to-angle line, and the amount of crystalline lens rise above this line gives you a lens rise. So any lens rise more than 600 microns could be little tricky. If you're using automated machines which are using infrared cameras, make sure you're not taking down, including the pterygium or the pigmented conjunctiva or a blood vessel from the side. A lot of times this will probably make you plan a smaller lens than required. Sometimes there could be a limbal scar which could probably give you a white appearance, and you may have end up planning a larger lens. So always do a manual edit. So I've trained my technicians to take a scan or on a Cirrus machine and then manually edit each patient over time, and we perfected it. Now white to white, as I said, if the discrepancy between both the eyes is more than 0.2 millimeter, please recheck. If the astigmatism is more than 2 diopters, please take vertical measurements and also match it with the keratometry of the patient. Size determination is one of the most important points. I think we all will agree, Dr. Pupil, Dr. Bianchi, and Dr. Patwardhan, that the white to white measurement is one of the most important hallmarks of planning a good patient. Now, if the astigmatism is high, you need to plan a little higher vault and a little tighter lens than normal, because if you have a loose lens in an astigmatism, the lens will tend to rotate. Now, this are some tricks which I borrowed this slide from my friend Dr. Himanshu. Now, these are the variations, recommendations by the company. How can you plan? So let us say you have a white to white diameter between 10.4 to 10.64. I would recommend an 11.75. If it's a spherical IPCL. But in case it's a toric lens, I would go in for the next higher lens. The reason being, a 0.25 millimeter larger size results in approximately 100 to 150 microns higher vault, but then it ensures that there is no rotation. And if there is no rotation, the toric lens tends to give you far better results. So in case of toric IOLs, in my practice, go in for one size larger. I would have gone in a normal situation. This is my workup sheet. In case there is some special note, we put it there. Now, peroperative learnings are always achieve a maximum dilatation, never be in a hurry. If the patient is not well dilated, wait. And in case you've taken the patient inside the theater, you don't, you could put phenocaine or some adrenaline in the eye or epinephrine to dilate. Make sure dilatation is always complete. Make sure that the IPCL opens on the iris. Avoid iris manipulation. Touching the iris will constrict the iris, and then you're in trouble. Overinflation with viscoelastic pushes the iris backwards, and then you will have trouble putting in the IPCL behind. Avoid touching the center part of the phakic IOL because that's the thinnest part and you can induce cataract. Meticulous viscoelastic removal is recommended. Now, these are the different positions and vaults. As I said, 350 to 600. With the new lens, the phakic IPCL, the new version, it's got a central hole and you will have a basic vault of 400, 450, come what may. It seldom goes beyond that. So that's a safety factor. And with this lens, I have patients where I have vault of 1000, even 1100, and the patients are doing fantastic. No glaucoma, no angle closure. So that's the beauty of this design. Now, these are some photographs from the literature for some attendees to understand. This is what we mean by the vault of the lens, the distance between crystalline lens and the posterior surface of the lens. This is one of my patients of keratoconus. This was the first mistake I made. I had an anterior chamber depth of 3.1 millimeter. I planned the lens. I went in and see what happened. The angle is actually closed here. It's a closed angle. So the central AC depth was good, but I had not done an OCT angle measurement, and the gonioscopy was also not done properly because there was a slight scar in the center. We missed it. So after that, I made it a point that whenever I'm planning a phakic lens in a keratoconus patient, I need to do a detailed gonioscopy and an OCT to see and measure the angles. I would probably go in for an angle more than 45 to 50 degrees in a patient of keratoconus because these patients tend to vault unknowingly and they surprise. Giving a contact lens trial for these patients and visual acuity workup. A lot of these patients, you can actually, there are some patients you can think that, this patient is wearing this glass, you've done a cycloplegic refraction, but do a contact lens trial patients, especially if the patient is anisometropic. Because a lot of these times when you do a surgery, IPCL in these patients, they are wearing uncorrected or low corrected power in one eye, and you correct both the eyes and they will have some problems of balancing and stereopsis. So these are a few things which I would recommend. The learnings would be case selection, exclusion criteria, investigations are to be very, very meticulous. Measurements have to be very specific, and special situations where you have very unique situations, corneal scars, you see an iris bulge, you see a lens high rise, you have a very flat cornea or a very steep cornea, please be careful. So thank you.